So we're going to be talking about the cardiac and respiratory surgical issues in the newborn. This is one of our talks for the Child Health Transport team. So the first thing that I thought of when I was going to present this was that this is pretty scary stuff. When you think about cardiac or thoracic surgical issues in the newborn, that can seem quite dramatic, and hopefully by the end of this presentation you won't feel like doing that. So what are the objectives? We're going to cover a couple of main respiratory categories of congenital diaphragmatic hernia, congenital cystic adenomatoid malformations, which are also known now as congenital pulmonary airway malformations, or CPAMs. Under cardiac, we're going to look at conditions managed through thoracotomies, and then conditions managed through sternotomies. And the hope here is to give you some education that you can use to establish some background knowledge or build on your background knowledge, such that if you are transporting a child with one of these preoperative or postoperative conditions, you can be aware of some of the things you need to watch for. So the first is to discuss CDH, or congenital diaphragmatic hernia embryology. The exact cause is actually unknown for CDH, although of course there are many theories. The main theory, though, is that as an embryo you have something called the pleuroperitoneal membrane, and the pleuroperitoneal membrane will ultimately form the diaphragm. And so if there's any condition that leads to interference with the development of this membrane, you can get a diaphragmatic hernia. The other possibility is that there's environmental factors which may disrupt mesenchymal cells in forming the diaphragm. The reason that this theory is present is because there are known medications or chemicals which can interfere with diaphragmatic development. So it's postulated that it may be some mothers that is, who are exposed to something in utero, it may get into their system and interfere with diaphragmatic development. So what is the impact of having the bowel present in the chest? First of all, pulmonary growth may be inhibited. There may be less branching of the airways. And ultimately, if you have less pulmonary tissue, because alveoli are paired with blood vessels or capillaries, you can get an interference with the arterial distribution. Once you get an interference with the arterial distribution and there's less pathways for the blood cells to travel through, the residual blood vessels may become hypertrophied. You get smooth muscle hypertrophy, and as these blood vessels become thicker, they become more resistant to blood flow, and you can develop pulmonary hypertension. One benefit of working here in Manitoba is that we are part of the Congenital Diaphragmatic Hernia Study Group, which was founded in 1995. And the purpose of this study group, which now has over 7,000, probably even by now close to 8,000 infants worldwide, is that it's a very large repository of data that one can use to determine how your center does compared to others, and whether there are any aspects of care in the diaphragmatic hernia group that you would want to improve upon. The leaders of this are one pediatric surgeon and his spouse, who I believe may be an epidemiologist, Kevin and Pam Lally, who are at the University of Texas. At the timing of this presentation, there were 22 publications. There have been more since I put this together. So if you're ever looking for information on diaphragmatic hernia, this is a very good resource, their group. And I put the website up there for the database if you ever want to go and get information. So as of 2013, which was the last data set I had, how are we doing? We had submitted 15. I can tell you now we're up to 27. And the CDH registry had 2874. You may question why, if I said there's 7,000, Not all entries have been put into the database in its current form. So, but out of those 28, out of the total, you can see that Manitoba is different in that most of ours are inborn compared to the registry, which is 50% outborn. Most of them, a little fewer males here than in the registry. The birth weight in Manitoba is a little bigger, and gestational age is similar at around 37 weeks. And prenatal diagnosis in Manitoba, thankfully, is 100%. I should mention that whenever you're looking at these kind of numbers, when you recognize that we only have 15 cases, you have to realize that the numbers may be a bit skewed. When we look at defects, isolated CDH is by far the most common. Repairs are done in 87% here in Winnipeg. Reason for repair not being done would be if the infant died or had multiple anomalies and the family opted for palliative care prior to repair. And as with the registry, almost 4/5 of all defects are on the left, with the minority on the right, and very few are bilateral. If you did come across a child with bilateral diaphragmatic hernia on transport, for one, they likely would not survive because they'd be quite sick, and secondly, it would be quite common for them to have additional chromosomal or other anomalies, which would complicate their course. Survival is, interestingly, even with our small numbers, very similar to the CDH registry. We're looking at 73% survival compared to 70%. For isolated CDH, it's a little better. And when we look at outcomes at 30 days, we're actually not that different than the registry. So about 40% of infants will be on O2 still at 28 days of life, and 64% versus 60% in the registry on room air. One thing that's important to recognize is that prematurity complicates, as you might expect, survival rates in CDH. This is a graph that was published by the Congenital Diaphragmatic Hernia Study Group, demonstrating that once you get below 37 weeks, survival starts decreasing. Overall survival under 37 weeks is only 53.5% compared to the near 75% for isolated CDH otherwise. Some of you may recall we did have a 31-weeker who did die here at HSC, but that infant also had significant spinal abnormalities. So what about CPAM, or as I mentioned, CPAM? It's a very common anomaly. Almost certainly when you do transport, you're likely to encounter a baby who antenatally was diagnosed with CPAM. It has an incidence of about 1 in 10,000, although it's very clear that we see, just like gastroschisis in Manitoba, we seem to be a bit of a hotbed for CCAMs. The frustrating thing with CCAMs, which makes it very, very difficult to prognosticate for families, but also to predict if you're going out on a transport for a baby antenatally who has a CCAM, is how they'll be at birth. About 50% of babies will be found to be asymptomatic, and the remainder tend to have mild to moderate respiratory distress. It becomes difficult to counsel families as well when you don't know what the exact outcome will be. So in many cases, even when the CCAM appears to be large, unless there's the presence of hydrops fetalis, suggesting that there is obstruction of cardiac inflow through the superior vena cava and through the inferior vena cava, it's very unlikely that you're going to be able to predict how these children will be at birth. But what is a CCAM? Well, a CCAM, by definition, it's congenital. It's cystic in nature, and it's adenomatoid. So it has some cystic tissue, some firm tissue, and it's a malformation. So it's a malformation in the distal bronchi or bronchioles, and what you get is this, in a type 1, a very big cystic structure, and it can be complex. In type 2, which occurs earlier in life, in the 3rd week, what you have is dense tissue with additional smaller cysts between the tissue. And in type 3 and 4, what you get is a microcystic abnormality where bronchi or alveoli are replaced by this very adenomatous or glandular looking tissue. So in terms of pearls, type 0 are lethal and have large proximal cysts. Type 1, which is the most common, 60 to 70% of the time, often are single 2 to 10 centimeter cysts. The problem with this condition is you can get much like the issue in meconium aspiration syndrome, where you get air getting in sometimes but not getting out. You can also get large cysts having dynamic obstruction of the adjacent airways. And type 2, which is only about 20%, is much more likely to be associated with other anomalies. Having said that, in all of the CPAMs I've seen, I can't recall a baby who had a CPAM with an associated abnormality. That's not to say it doesn't happen, but I wanted to ensure that you didn't think you'd have a high index of suspicion for other anomalies with this. Type 3 with the small cysts mixed with solid tissue. These were the ones that are usually asymptomatic, and I think are actually ones that perhaps we see more of. The type 1s may be lethal, so you don't see them, but the type 3s we see. The type 4s I can't say that I've necessarily seen, which would be the macrocystic, with a cyst up to 7 centimeters in size. And these are the ones which, if not removed in childhood, have a low incidence but can form a pleuropulmonary blastoma, which is a type of cancer. And this is where the controversy lies with this condition. To cut or not to cut. And the reason that's the controversial point is it's difficult to determine what will happen to these kids at birth, and it's even more difficult to determine what will happen in the long run. Certainly less than half, but can be associated with hydrops. But 60%, even when they appear large in utero, may actually vanish by the time of birth. There's also some reports of postnatal regression. Now, given that historically 50% will be asymptomatic at birth, in discussions with surgery, they certainly would like to see them, so that's one reason that you could be asked to do a transport, is to bring a baby from up north who may have some symptoms and needs to see surgery. But also, the usual recommendation is to do an X-ray, look for signs of hyperinflation, again from the adjacent airways being obstructed, and also to do a CT scan at a few months of age. And then down the road, given the potential for malignant change, there's also a potential for recurrent pneumonia, as these areas of lung do not clear secretions well. Some of these kids will actually undergo resection of their CPAMs at a later time. If they actually undergo a lobectomy, that is curative. As I mentioned, a conservative approach is certainly one that is being entertained more and more, especially if they're asymptomatic. And this complex slide, what it does show you is when you start off with 74 of these malformations which are identified, 72 of them were live births, and of the 72, 71 were in fact managed conservatively. That would mean observation. Of the 71, 3 of them had elective lobectomies, either due to the parental request or because of a family history of cancer in the lung. But of the 68 that were remaining, what I can tell you is 65 of the original, or 65 out of the 68 were fine in the long run and were conservatively managed as children. So when you know the likelihood is that these children will likely do well in the long run, certainly if you're asked to go and transport one of these infants, rather than indicating to the families that surgery is most likely, the fact is in a modern cohort, surgery is actually less likely. So moving on to congenital heart defects, I think it's important to remind everybody that not all heart defects require surgery as neonates. One such example is atrial ventricular septal defects, which is not on this list, but came to mind because I was handed a consult yesterday and asked if I was concerned. These kids, provided that the the AVSD is not associated with signs of heart overload in utero actually may make it to several months of age without needing anything done. So they behave like a large VSD. So in similar circumstances, children with mild pulmonary stenosis or even double outlet right ventricle with mild pulmonary stenosis, which controls the amount of blood flow going to the lung, may in fact not require anything until several months of age. Certainly muscular VSDs may never require surgery. As the child grows, their VSD may close, and ASDs do not become an issue until much later in life. But what about surgical congenital heart disease? Surgical congenital heart disease generally falls into three categories, which I've shown below. There are those conditions which are dependent in the infancy or newborn period on left to right ductal flow. The example of that would be your right-sided obstructive lesions, such as pulmonary atresia or tetralogy of Fallot. In these cases, unless you have a left to right shunt across the ductus arteriosus, the children cannot survive. And for that reason, prostaglandins can be life-saving. The second possibility is that you have a dependence on right to left ductal flow. Examples there would include coarctation of the aorta and hypoplastic left heart syndrome, where if you do not have a ductus open, there's no way to perfuse the descending aorta. And then the other types of surgical congenital heart disease are where you have, instead of serial circulations, where your circulations work together, you have parallel circulations, where you've got a pulmonary and a systemic circulation which are not communicating with each other. The classic example there would be transposition of the great arteries, in which your cyanotic blood is being recirculated to the body and your oxygenated blood is being circulated to the lung. But also total anomalous pulmonary venous drainage would be a second category there. Another way to look at congenital heart defects has nothing to do with surgical, but rather has to do with the problem, the physiologic problem. I prefer this to the classic cyanotic and acyanotic, because this actually helps you figure out when you take a transport call or you have a problem in front of you, it really tells you what class of condition it might fall into. So for example, times when you have decreased pulmonary blood flow, examples being tetralogy of Fallot, tricuspid atresia, pulmonary atresia, and so forth. The problem there is you're not getting enough blood flow to the lung. If you're not having enough blood flow to the lung, they present early when the ductus begins to close. Typically these kids present by 24 hours of age as being cyanotic. Alternatively, you have problems of increased pulmonary blood flow. These are the so-called mixing lesions. So that would include ASDs, AVSDs, VSDs, PDAs, even arteriovenous malformation in the peripheral circulation. These types of circulations suffer from the problem that over time you develop heart failure. It's important to specify over time because that explains why you tend not to see these presenting right at birth. These typically are the kids who you may be asked to pick up in the north, let's say, who have gone home or they present to an emergency department at Children's and they have feeding difficulties, falling asleep at the breast, sweating with feeds, breathing quickly, and this takes 3 to 4 weeks, if not longer, to develop. So these tend not to present right at birth. And then the last category is decreased systemic blood flow. So in these conditions, you have an obstruction somewhere in the left side of the heart. It may be either in the heart, such as hypoplastic left heart syndrome. It could be at the valvular level, such as aortic stenosis. It could be at the arch, such as coarctation of the aorta or an interrupted aortic arch. But this tends to present after a few days of age. So I think it's important, or anywhere from birth to a few days of age. So it's important to recognize that by categorizing them in such a manner, you often are able to help determine which type of lesion they fall into. Now this is for congenital heart defects. Of course, this doesn't include cardiomyopathies or myocarditis, which you would see on the pediatric side. But if you think about it, if you had a hypertrophic cardiomyopathy, there would be a child that would have very stiff ventricles and be unable to receive blood supply. So if it's a right-sided problem, would have decreased pulmonary blood flow. If it's a left-sided problem, would be in shock from decreased cardiac output. And myocarditis would be a similar situation where poor contractility would lead to decreased systemic blood flow. So whether you're applying this to neonatal or you're applying it to the pediatric side, there's applicability of this way of thinking to both. Now, coarctation of the aorta is an example of a condition which can be repaired through a thoracotomy rather than a sternotomy. The typical presentation is around 9 days, and the reason for that is that the ductus arteriosus often begins to close first at the pulmonary end, and it's like a zipper as it closes towards the aorta. Once it closes at the aorta, the shelf that is the coarctation blocks the blood flow and causes strain on the heart. Until that point, as long as the pulmonary side, as long as the aortic side end of the ductus is open, the blood, as it's going through the arch, can go around the obstruction. The presentation is typically oliguria and lactic acidosis with tachypnea and respiratory distress. Again, as I mentioned, you can manage this with Prostin. The importance of getting an echocardiogram is to determine the side of the arch so the surgeon knows which side to do the thoracotomy on, as some people may have a right-sided aortic arch. The options for repair, just in case you're picking a baby up and you wonder what they're talking about, sometimes they do a resection of the coarct with an end-to-end anastomosis. Other times, for a long coarctation, they'll use what's called a subclavian patch for long segments. And when there's very long gaps, the possibility of using artificial tissue or cadaveric tissue to make a conduit may be entertained. Complications. The problem that we most often face is that of the injury of the recurrent laryngeal nerve. The left recurrent laryngeal nerve loops underneath the aorta, and as it loops underneath the aorta, and I'll show you with the cursor here, as it comes down and loops underneath the aorta, that is where the ductus arteriosus is. And so when the ductus arteriosus, that's where the ductus is, that's also where the site of the coarct repair may be. And so when you're working in this area, you may cause injury, as we see in typically 70% of ligations for for a patent ductus arteriosus. What we see is injury to this nerve at the site of the repair or ligation, and what happens is the patient is left with a paralyzed left vocal cord, which may interfere with phonation and also protecting the airway. So after coarctation repair, you may actually have residual coarctation. So it's very important when you're going to get one of these patients and bring them back, check a blood pressure in the right arm, check it in the leg. If there's a significant discrepancy, you may still have a residual coarctation. Over time, these may re-coarct and need to be sent back for dilatation or repair. Whenever you're touching the aortic tissue, you can get an aortic dissection, you can get pneumothorax, bleeding is a possibility, which then moves on to hypoplastic left heart syndrome. So this is an example requiring a sternotomy, although there are now hybrid procedures that I won't get into. Now, mostly this does require a median sternotomy. I did mention that there is a transcatheter procedure, and it involves the use of something called an Amplatzer device, which you may hear about. Amplatzers have been used most typically to close ASDs, and they basically get caught in the ASD and then tissue grows around them. The Norwood procedure is the procedure that is used to treat the hypoplastic left heart, and this involves augmenting a hypoplastic aortic arch, and the way this is done is by disconnecting the pulmonary artery and using the pulmonary artery to attach to the aortic valve. Excuse me. When you do that, you need to use either an RVPA conduit which is inserted through a ventriculotomy, or you use what's called a modified BT shunt from the subclavian artery to the pulmonary artery to control blood flow. The key there is you need to ensure adequate intraatrial blood flow, because you're now allowing mixing of blood with blood going out the the RV towards the aorta. But in order to get blood out the aorta, you must ensure that the blood is coming through an atrial connection. And so an atrial septectomy is typically done to enlarge this communication. And I'd like to show you a cartoon video which demonstrates this, so I'll help to understand how the Norwood is done and where things may run into problems after.
The one good pumping chamber, which in hypoplastic left heart syndrome is the right ventricle. That ventricle has to pump to the body. So you have to connect the arteries to the lungs and the body in such a way that all the blood goes out to the body without any obstruction.
In HLHS, the aorta is usually too small. So we correct that by putting a patch on to enlarge it.
And that's done by connecting the pulmonary artery, which comes from the right ventricle, to the aorta, and then usually putting a patch on to finish the connection of those two blood vessels and enlarge the aorta.
In addition, you have to prevent blood from backing up inside the left side of the heart. So you have to cut out the partition between the two upper chambers of the heart. And then the third principle of the Norwood operation, or the first stage operation, is to provide some restricted blood flow to the lungs.
What we call pulmonary blood flow. And we do that by placing a shunt, or a small tube, from one of the systemic arteries, or arteries that goes from the heart to the body, to the pulmonary artery.
That is enough flow that you can get enough oxygen in the bloodstream, but not so much flow that you have resistance problems.
So when you do that, it becomes clear that if you use a Blalock-Taussig shunt, you could have blockage of that shunt. If you get blockage of the shunt, you lose perfusion of the pulmonary artery, and the patients will present with cyanosis and shock. Also, the challenge had been previously, before the Sano shunt, or the RVPA conduit as it's more properly known. The problem had been that if you allowed a baby with hypoplastic left heart who had undergone the Norwood to have hypotension, they would lose perfusion of the lungs. And so it's important to monitor fluid status, and it's important to keep them well hydrated and to maintain a good blood pressure. Now, the complications post-hypoplastic left heart syndrome, clearly with sternotomy, there can be dehiscence, infection, or mediastinitis. Thankfully, recurrent laryngeal nerve injury is uncommon at only 1 in 20, but phrenic nerve injury, so a paralyzed diaphragm, can be about 1 in 30. Low cardiac output in about 1 in 6, so again, you have to watch and make sure that they have good blood pressure, good urine output, low lactic acid when you go to transport these infants. And if there's over-circulation, if you don't control the blood flow enough, these children can go into heart failure. So if the lungs are wet on x-ray when you go to pick them up, it would be a good question to ask when their last diuretic was, and if they need some extra diuresis before you retransport them. Timing of operation, this is often a question that will come up, is a baby's born with hypoplastic left heart syndrome, how quickly should you move them out of Winnipeg and get them to Edmonton or Vancouver, Montreal, or Toronto for that matter. If you do it sooner, there may be shorter hospital stays, less total days of central line access, less likely to be intubated, and less milrinone. What we know is if you do not intubate them before they go for surgery, their neurodevelopmental outcomes appear to be better, and we're not entirely sure why, but it does seem to be replicated in multiple studies. If you do it later, you may allow their PVR to decrease, and the thought was better short-term morbidity and survival. When you look back in 2007 at how long people typically waited until taking them for surgery, in fact, most centers were taking them within 5 days. I can tell you, while I was in Edmonton when I first moved there, we were typically taking them between 7 and 8 days. So we were certainly in the minority. As I mentioned, multiple studies have indicated that pre-op ventilation can be harmful. And so my personal bias, and certainly the bias now, at least in Edmonton, is to take them quite early, around 3 days of age, before you get to the point where they run into heart failure, oliguria and lactic acidosis, and need to be intubated. So as far as pre-op strategies, if we have them here, and you're thinking about, or you're asked to transport one of these infants, the ideal situation is to have a QP/QS no greater than 2 to 1. And the reason for that is, excuse me, the reason for that is because once you get over that, they begin to become oliguric. And in this is an example of a study back in 2006 where they actually looked at such kids, though, that were having high shunt fractions, and they looked at intentional ventilation in 92 to 95 versus primarily looking at after-load reduction. So that would be using milrinone as an example, or nitroprusside or nitroglycerin. And again, what they showed in this study was an odds ratio of 14.5 for putting patients at risk of preoperative organ dysfunction. So it's not only the neurodevelopment, but you can actually run these kids into significant organ dysfunction if you allow them to become ventilated prior to surgery. Which creates an interesting situation when you're thinking of transporting these kids. Do you intubate them for the transport or do you not? That's something that we as a team need to discuss, because again, if you intubate them, you may make things worse. Interestingly, when you looked at survival, survival when they stopped ventilating also improved up to 87%, although that may of course have had something to do with also improvements in technology. And in-hospital mortality were predicted by two things in this study, which were ventilatory support and organ dysfunction. So again, the two of them are not mutually exclusive, and we need to do our best to, I think, focus on afterload reduction, diuresis, and maintaining good urine outputs and low lactic acids prior to transport. That's it. Thank you.